Hello everyone, I am doing a presentation on cankles, the ankle series. Just a little humor before getting started on our discussion of the presentation. I'd like for us to familiarize ourselves with what the radiologist is looking for. Do we know why we are taking certain images? I have a few injuries listed and some of the views that will need to be done to confirm a diagnosis. Here we have a labeled ankle. We've got a tibia, a fibula, lateral malleolus, a tibio-talar joint, talus, and medial malleolus. The medial malleolus, the talus, and the lateral malleolus. These three parts are important when referring to this part of the anatomy. The most common term used is the ankle joint. Other sources use ankle mortise or mortise joint. The lateral malleolus of the fibula and the inferior surface of the medial malleolus of the tibia make up the articulations. The articulation is synovial hinge joint. This joint can maneuver in several ways such as dorsiflex, extend, plantar flexion, abduct, or adduct. More of the mortise will be discussed in a later projection. Quiz. If a patient presents to the emergency room for a right ankle injury, which projection should be done first? A or B? If you chose A, you guessed correctly. Awesome. First things first, before we tell our patients to be still, don't move, before we start rotoring the button to make exposures, we as technologists should employ patient care. The more information our patients receive from us, the better outcome will be given towards their cooperation. Also, all projections or all ankle positions will have an SID of 40 inches on a 10 by 12 imaging plate lengthwise. The AP ankle is the first projection in an ankle series. We want the body part centered on the imaging plate. We want those toes up and pointed to the ceiling. We also want the CR perpendicular through the ankle joint midway between the malleoli. Tell the patient to be still, don't move. There should be a projection of the distal tibia and fibula ends, the proximal portion of the talus. Please no rotation. Overlapping of the tibiofibular is great. Talus overlapping the distal fib is good. Can't forget the tibio-talar joint space. We need to see that. Pop quiz. What's the tube angulation required for an ankle mortise medial rotation? You are correctamundo. The answer is C. No tube angulation, only body part rotation. In most, if not all, the patient is already in position for the next projection. Just rotate that leg medially, inwardly, or point it towards the other foot 15 to 20 degrees until the intermalleolus is parallel to the board. The mortise joint will be in profile. The three sides should be visualized. The articulations you want open are the talofibular and the tibio-talar. If the anterior tubercle of the tibia and the superolateral part of the talus with the fibula is closed, decrease your rotation a little. Next is the lateral projection of the ankle. This is also called medial lateral. Any guesses to why? You're absolutely right. The beam is entering the medial side and exiting out the lateral side. Roll the patient over on the affected side and dorsiflex that foot 90 degrees, not just the toes. This will prevent lateral rotation. We want to be able to see a lower 1/3 of the tib fib, the ankle joint, the tarsals, especially the fifth metatarsal. The fifth metatarsal will show a fracture if there is one, and it's called a Jones fracture. We want to see the tuberosity, the fibula over the posterior half of the tibio-talar joint, and that's also called the domes. We want those superimposed. Next pop quiz. In order to demonstrate any soft tissue swelling for a lateral ankle injury, what technique or exposure is needed? You got it right again. Low KVP. Lower KVP increases contrast and gives better soft tissue visibility. Here are a few projections of the Mortise and the lateral. On the Mortise side, you'll see there is a 15 to 20 degree rotation of the foot. You've got the fibula and the tibia. You've got the tibiofibular joint, and it's slightly open, and you've got slight opening of the anterior tubercle and the talus and the fibula. Talus and the tibia. Excuse me, correction. And on the lateral, you got your fibula on the posterior side of the tibia. And then, of course, we want those domes superimposed. You've got your calcaneus showing. You've got your talus and your navicular. And then also that fifth metatarsal is also showing. That foot is not dorsiflexed for that image. I like this slide because we're always saying don't move, hold your breath or whatever, and then the patient goes, what? So let's see what's wrong with these images. The first image is the lateral foot or lateral ankle, and we want that foot dorsiflex. The fibula is not posterior to the tibia. The image next to it, of course, is the ankle mortise, and then there's rotation a little bit too much, and the foot is not dorsiflexed. So for this lateral ankle, there is some clipping of the anatomy, and look at this fibula. It is all the way out. It's not posterior to the tibia, so there's no superimposition there. And for the AP ankle, there is like a bead or something, or a zipper of the pants in the soft tissue of the AP. And that concludes my presentation. I thank you so much for the opportunity to share with you about the ankle series. You guys be great.